So there was one thing that I noticed that security did, and I didn't see anyone from nursing or the medical team do, and that's universal precautions, things like gloves and other things to protect yourself, so making sure you don't have things around your neck, maybe a mask to protect your eyes if the patient's spitting, and gloves, necklaces, IDs, and making stethoscopes, and making sure that you are safe is a priority, because at that point, even before the Haldol and the Ativan, he was held down pretty quickly, and I think we are in a safe place in terms of the other kids in the ED, in terms of him not harming himself or others. And in reality, Haldol and Ativan, to get them drawn up and into the room, will probably have taken longer than that whole code took. I don't know what your thoughts are on it, but it would have taken 5-10 minutes to get those medications out of the IPSS, bring them into the room. Other safety issues that you guys notice as people who do this all the time, because the adult side I feel like has a little bit more experience with this, and fortunately we don't, but were there other things that our staff, our nurses, our residents could have done differently?
I would say that if you have somebody that was like he was, out of control, confining them or corralling them is your best option, because you're not just protecting him and yourselves, but you're protecting the other patients. So whoever got him into that room did a great job. You know, you wanted to sit in the room, and as soon as he got in there, that was it. He's not coming out, no matter what. So if you guys have to protect yourselves or protect the other patients by standing in the doorway, because a lot of times just standing in front of somebody, they decide that, oh, I'm not going out that way. You know, but obviously, if he's dangerous, you know, do the best you can to protect the other patients and yourselves until we can get there.
Would you have shut that door, or no? Is it safer to leave it open so that if
you shut that door, he's going to feel like he's confined, and that's it. He's got to get out. You know, if you can do it where you can keep him in there without shutting that door, that's definitely a better course of action. You know, but a lot of times it's patient specific.
Yeah.
So it's really hard to say. You can't say all cases are this way or all cases are that way. You guys know that with medicine.
Right.
And there's levels of aggression also, just like there's those levels of restraint. There's levels of aggression. So when there's the, do you want to go through them? So there's the angry, sort of agitated teenager that you probably see at your school more often than not. Then there's someone who's actually doing property damage, so tearing things off the wall, that's the next phase. And then when they get to actually being injurious towards others or themselves, that's the highest phase, and that's where you really need to jump straight to restraints for safety. I'm not sure if he was in the property damage phase. I don't think he seemed to be in the injuring himself or others phase yet, so I think you had some time, and I think you guys acted really awesome to start off. You sort of said, okay, we're going to get this patient in this room from a safety standpoint. Someone went to get security, and everyone didn't go in the room, which sometimes we'll see happen in a real medical code as well as this type of code, where there's too many cooks in the kitchen. And I think that Carolyn did a great job sort of with crowd control, trying to take the lead. The only thing that I might do a little differently is letting other people do the hands-on stuff.
Well, and then I stepped.
You did?
You did, yeah. Because I thought that. I was like, this is my bossiness, sorry.
It's not stupid. Well, it was great.
I wonder about, though, like in this section of the ED where you have like a closed end, like bringing him here, we confined him already by getting him into this section. But if all these rooms have been filled and he had been going to the other rooms over there, and then, or do you always bring them on this side of the box?
It's our last place.
Yeah,
we would never.
Yeah.
More often than not, he would end up here. He would end up on the other side.
You know, more often than not, he would end up on the other side. The reason we brought him here was solely because there's real patients on the other side, and
I'm
because
just wondering,
it is a
because the way
singular
that I
case.
think that we got him into the room was that we have walls. Walls are our barrier, and then we all had our shoulder force kind of as the fourth wall, and I'm wondering about on the other side there, how we would have circled him better, and you know, there's a lot more ways to get out and move into different places.
If you were full up, would you have gotten somebody out of another room to get him in? I mean, you would have just pulled the most stable kid out and sort of tried to get him. Or we have
probably room 9.
Right.
Whoever was in room 9,
just bring him out and
So in case you didn't notice, room 9 and 10 often end up with some of the psych patients. In room 9, because of that second level of physical injury to the environment, everything can be removed from that room. So that's why, if you haven't noticed, when you go in that room, you're like, why is there no stethoscope in here? I mean, otoscope in here. It's because we remove everything from there for the safety of those patients.
And it's like just a wall that's closed to block. So you can transition it open and close based on your needs. But yeah, sort of corralling and not getting upfront and aggressive in the face of the patient, but just sort of easy guidance. You can a lot of
started to be addressed at the end, and I just want to bring this up. I know you guys have to go over to clinic. Is how we think about these patients. So oftentimes we think about psych patients as a different group of patients than our other patients. But what was this patient's chief complaint or presentation? How would you sort of try to couch it? Psychosis, aggression, maybe, altered mental status, possibly. So what things other than a psych history, which sometimes these patients will have, or in addition to a psych history, can cause this type of behavior?
Ingestion.
Okay, what type of ingestion?
Either drugs, alcohol,
What type of drugs?
the hallucinogens, or PCP.
So PCP, cocaine, other sympathomimetics. So I heard someone at the end trying to come up with a toxidrome, which is using vital signs and physical exam findings. And someone mentioned the tachycardia, the diaphoresis, and the agitation. So that was great. So how about non-toxicologic or psychiatric etiologies?
Telling her right away, basically, said as soon as we get this kid restrained, let's get a D-stick for, hyperglycemia. Is this kid DKA actually totally, or hypo?
If it's an organic cause, you just want to think about some electrolyte abnormalities we might be able to see, or just his acid-base status, and then people are asymptomatic.
Great.
We don't really have a good history of what happened prior to the psychosis. Was he sick? Did he have also was he get a temp on him?
So what are you thinking about with the town?
Just, if we think about it, just altered mental status. I don't know if that would also be part of the toxidrome, but if he was just,
Could be part of the toxidrome, certainly, the febrile, but were you thinking of an infectious disease etiology?
maybe, and he's just, and he's either it started off as a seizure and now he's post-seizure, or I don't know.
Okay. So neurologic issues, I would couch that into another large group of possibly brain tumor, encephalitis, meningitis, and especially if we're going to be virtually taking away any physical exam or assessment ability we have with something like Haldol has a very long half-life, we're going to need to keep all these things in a really broad differential because now we're going to have a sedate patient.
You could see it with hypoglycemia, severe hypoglycemia.
So the D-stick, I think, is crucial very early on. And Karen mentioned the other day a differential that I didn't think about at all until with allergic reactions, I guess, are starting to be described in the literature with altered mental status and anaphylaxis presenting as altered mental status. So making sure to do a good primary and secondary survey, so evaluation for rashes, wheezing, stridor, things like that.
The other things I think of are neurocutaneous disorders. Lupus cerebritis can present in this fashion, and if there might have been a history of trauma as well, a closed head injury.
I've seen a patient with thyroid storming.
Another good
As
one.
well. He'd had a past history of agitation, but it was the same thing. This 16-year-old male came in extremely agitated. Had been treated as a psych patient for 6 months.
The feel we have recently.
So pheochromocytoma.
Yeah,
So I think these all bring to light not only if someone has a past psych history, because pretty much all of our, not all, but many of our patients now are on ADHD or psych meds of some type. Or
20% of kids now are treated with some sort of psychiatric, or diagnosed with some sort of psychiatric illness.
So hearing about those things should rule out all of these things. Other medical
I think the only
management
other
questions?
point that, like, when you came in as the psych attending, you're like, oh, I've looked in his records on a computer, and here's his,
Yeah.
and that would have been a fast, I mean, we have that ability now, that actually for all of the downsides of computer stuff that drive us crazy, being able to pull up a kid's record and have allergies and meds, and even if it's 2 years old, at least you
But
have
can't we not pull up
framework.
the psych histories, any
So
psych
here's-
records?
So we can't do their notes that they do here, but when they get discharged from like YPH, the dictation appears in the computer. So, but yeah, we don't have access, like when psych writes their evals of kids and they come up to the floor, we don't have access to their notes.
In a way, I thought it was kind of good actually that we didn't know his psych
Yeah.
history, because again, it was like, we were talking about, well, it was Lawrence, we know it's a mock code, but still like not knowing anything, like you're saying, like still running it like a code, at least initially, until he's like stable and we've
Yeah.
gotten some level.
And I'd encourage you not to take, and this is what I was trying to say before, just to be more transparent about it, never to take a psych history meaning a psych diagnosis, because they're not mutually exclusive, and this is the time where you're going to miss something, and that's why they come here instead of going to YPH or a facility that's purely doing psychiatric evaluations.
I think my point was more just meds and
Okay,
if the kid
allergies,
was
meds.
immune.
More for that than the psych history, but is the kid hypothyroid or whatever.
You know, something you said, Carolyn, made me think you tend to have more than enough people in situations like this to have someone break off and call the school where he came from, because there's a nurse at the school or someone who can get to records, because it may be critically important to have some piece of information from the records at school. But we do that a lot during real life codes, have someone break off and call someone about something.
And you might get something like in your husband's field as a football coach. He's a football player and he had a bad head injury last night or something.
Right.
Excellent. So
I have one quick other question. Just in terms of recruiting resources, I know he was technically 14, but would sending someone down to the CIU just for extra hands or more expertise, I don't know how much they deal with like very agitated people.
they deal with it every day, all the time. They'd have the same, similar reaction to what these gentlemen had. Who was going to comment on it?
They're very hesitant if they're not 16. 16
even
and
come
older.
Yeah. I think getting more secure, we
More
can get
about
more
security.
security quickly if you
Yeah, it's not
need
that.
to. Like I know,
But as a male or a female that feels strong and empowered and maybe tough, like you said, don't feel like you should jump in there, because these guys are trained for it.
Right.
And we can talk about it and maybe even think about ways that we can train residents and other staff members. Our nurses have training in it, but
Even then, I was fumbling. We had a leg. I had the restraint on, and I didn't know what to do with it after it was on. Because security usually is in there. We can get it on, and they're the ones locking it, tying it to the bed. So we had it on, just I was not capable to actually then attach it to the bed. I don't know if you've ever been trained. You knew what you were doing with that, but you...
Didn't you go to restraint training?
Right. But again, I don't do it all the time.
right.
So
Yeah,
it's
they
not
did all
something
the
that-
restraints
any
with us.
restraint
yeah, so I think you've identified something that would be helpful to
Yeah.
you guys.
I have no idea.
No idea.
And much more importantly than the physical restraint training, the verbal restraint training,
Yeah.
which these guys are very skilled at. It needs to be able to think about that almost like you think about your ABCs. Instead of freaking out and being scared, you have some knowledge behind what you're going to be doing. Any other questions the nursing staff had or comments that you guys had? Feedback for Carolyn as the team leader. Did you guys have
I
an idea
knew
of
she
what
was
was
a
going
team
on?
leader right from the start. You know, I could hear her, I was following her, so I felt like she did a really good job of that.
Lawrence?
Just two quick comments. Like, in a situation like this, oftentimes it's the agitated adolescent that's big, strong, pissed off. And so when I think the team did a great job of trying to corral me. Like, I was running around and everywhere I looked, there was someone who was like trying to force me one way or another. But I got to the point where, I got past Karen and got past Chris and then I met the officer. And so the point is that you should never put yourself in harm's way, because oftentimes you could get hurt, and let the professionals know what they're doing kind of take it. So calling security right away is certainly a priority. And then after that, just being a patient on the bed, I thought you guys did a great job in actually restraining. I was trying my darndest to get out of it, and honestly, I had nowhere to go. And so the verbal kick tactics and just trying to talk him down as much as possible, get him into a secure place, and then physical restraints, I think worked really effectively. I felt once I realized I was restrained, sort of gave up.
Other questions people have?
Sorry, we
Yes, I can go. Yeah, so very quick summary, universal precautions, keep yourself safe physically and from infectious diseases. Think about it as verbal, physical, then chemical restraints, and think about it in terms of a code type situation. And I'd like to thank Michelle for organizing this, and Lawrence for acting in the security office.
Thank you.
Point of theatrical performance.